Good morning, ladies and gentlemen. My name is Edward Czerwiński. I am a retired professor of the Jagiellonian University and Senior Medical Director of FutureMed. Today, I have the honor to present to you the current guidelines for treatment osteoporosis. This is our sixth lecture. After previous one where I was talking how to calculate the fracture risk, and in this lecture I will tell you what means the imminent or very high fracture risk and how to find who is at very high risk and the consequences. For this lecture I will talk first about the definition of imminent fracture risk. I have a quantitative assessment of this, qualitative assessment, and then summary. First of all, I wish to say that I strongly advise you to read these publications I choose for many others, because every country has their own guidelines based off the international guidelines. So I choose the International Osteoporosis Foundation General Guidelines for 2019, and with those new guidelines with the very high risk 2020. Then NOF recently called Bone Health and Osteoporosis Foundation from US, the clinical guidelines quite fresh 2022, and American Association of Clinical Endocrinologists, which are different from the International Osteoporosis Foundation. First of all, we already know that the highest fracture risk is in patients who sustain the previous fracture, but the magnitude of the risk depends of the recency, when it happened, and the localization. Here we have after the fracture of proximal femur, the risk of the other side is 6 times higher. After the vertebral column, the risk of proximal femur is 2.2 higher, and for radius, twice higher. And the same relates of the time. And here is a very old publication from 1990, 26 years ago. And it's 4,000 person years, 10 years observation by Melton. And you see that within first 2 years, 1/4 of patient occurs. And what is also important to remember, that the clinical fracture has the strongest, the highest fracture is of 12. And here's a course it regards to hip, 61, spine, 42, humerus, and forearm. You also may see that the slope is the most to be on the first year and a little bit less. So there is discussion whether we should take the first year when the speed is highest one, or 2 years when you have the half fractures. Here will be perhaps half of the fractures. So what imminent fracture risk means a very high probability of subsequent fracture within 1 to 2 years after the prior fracture. You will come in the literature another term called very high fracture risk, and these are not the same, but means the same as the decision making. This is the very high is a fracture who have very high risk of fracture in the short period of time. And we have bone forming agents now, is teriparatide. Imminent fracture risk means a very high probability of subsequent fracture with 1 to 2 years. And very high risk means a very high risk in not necessarily in 1 to 2 years. However, those terms are used interchangeably with the imminent fracture risk. And we have now bone-forming agents, abaloparatide, aromatazumab. Advantage of that, what I talked before, is definitely superior efficacy than the anterior-receptive ones. They act much more quicker and are much more higher effective in reducing the fractures. And they are talking about this very high risk because we know that the best strategy of treatment is start with both forming agent and then continue with very cheap anti-disruptive. The problem is the cost. The problem is that the cost, and this is why we are concentrated on the very new guides and very high fracture risk. And the cost in Poland for anti-resorptive alendronate is €3 monthly versus €400. So only very, very few patients can afford that. Reimbursement is the issue of any country because there are huge money behind it. So we have two possibilities of calculation of the very high fracture risk. One is the quantitative, I will talk about later, using FRAX, and qualitative, which I'll tell in the second part of American Association of Clinical Endocrinologists guidelines. Starting with FRAX, we know that have enormous population, so can calculate almost everything. And just remind you, have a population risk of a patient, standard women with BMI 24. We have treatment threshold is the value of 10 years probability after the fracture, and upper threshold, which is 1 times higher the intervention threshold. So it is very easy to say that the imminent fracture is those whose value of fracture risk is higher than the upper threshold. Very, very clear, very precise, but needs some calculations and understanding. So here is our lady, 67 years old with BMI 27, and we take a chart from IOF, and we see that that lady have intervention threshold 19%, and upper threshold is 22.8. So she will be in the zone on the very high of imminent fracture risk if she overturned the number of percentage 22.8. Here is I told you on the oldest version in my previous lecture, there is a new fracture, beta, and unfortunately you have to pay for this calculation if you want to go for the adjustment. And here then FRAX beta version, which allows adjustment for various risk factors. And here are the results I showed you before. Patient 67 years old with T-score minus 2.3, and her major fracture rate was 12. And if she will have a previous fracture, so her major osteoporotic fracture risk is 19. So we know that she should be treated, and she is in high risk, but she is not at very high risk because she still didn't exceed 22.8. So we go for adjustment, and we can find that what kind of fracture, vertebra, hip, humerus, forearm, and we say she had a forearm fracture and was recent one within within 1 year, before 6 to 12 months. And we go for calculation, we have 19, and we have now 23. So if she had the fracture, if she had previous fracture, but many years ago, she is at high risk and must be treated. But if the fracture was recent one, so her risk is 23%. The simulation of recency of fractures, we started the patient who is 67 years old, and T-score is minus 2.3. So if she had a previous fracture, her risk is 19, so she is in high risk of fracture and should be treated. But if she have a recency of fracture, she say radius, her risk is 23, and spinal is even 33. So she will be at a very high risk, so she would need treatment with the bone forming agent. And please know that if she was very misfortunate and a previous fracture, family fracture, and glucocorticoids, her risk will be unbelievable 58%. And now, if she has osteoporosis, so you see, not the very changes. That means here we have recent fracture. That means here is high fracture, very high, and here is very high, and so not very. Here we have a change, okay, but many changes. If she was minus 2.1, so any previous fracture is exceed the category of very high risk, and all others and falls and so on. So the conclusion is that FRAX takes into consideration the recency, the localization, and the falls. So may find that women which have no osteoporosis according to WHO criteria might have very high risk, and this is crucial information. So those guidelines also describe the kind of decision and intervention. Again, I relate for reading the publications I showed you on the first slide. So if she is someone is a low risk, so is lifetime advice, consider MRHT and SERMs. That's something new. If someone is in high risk, consider, of course, anti-resorptive of others, including, of course, bone-forming agent, if someone can afford it. Very high risk, definitely between anabolic and bone forming. Bone forming is, I think, correct. And now Americans use anabolic, so bone forming agent, and then after a year or two, if once consider you have to follow it with anti-resorptive. Consider LOP just because you may hear about it. It is the idea of improvement of the bone strength, injecting a special kind of bone cement. There are some good publications, but personally I am not convinced that it will really works. Easy procedure, but I think we have to wait for the because investigation results long-term results. So this was the quantitative, and now we go for qualitative assessment, and this is by American Association of Clinical Endocrinologists, by opinion leaders. And again, we have the stratification of low risk, high risk, and very high risk. Low risk means age postmenopausal and no previous fracture. T-score more than -2 and FRAX probability of more 20 and for the hip. Then and you have the all of this. Then you have a very high risk if one of those exists. That means postmenopausal woman, prior fracture, osteoporosis, and say osteopenia plus FRAX. And what is the of our highest interest is the very high risk, and I will go to the details. And this is the method based on interview of clinical evidence according to the AC executive summary. They have 52 recommendations, and it is for a very high risk. So consider if the recency of fracture within last 12 months, fracture while if someone is on therapy, multiple fractures in patient who is of medication causing change in bone metabolism, glucocorticoids and others, very low T-score -2, high risk of falls and injury, and very high FRAX. That means MOF more than 30 and hip more than 4.2. Just remind you that those figures will not fit to every population. So how it works in the real world, it is the huge study of 115,000 of patients, and you see that within 1 year we have any fracture, wrist, pelvis, vertebra. Just to remind you that the MOF, the major osteoporotic fracture, as done by FRAX, includes hip, spine, radius, and humerus, but we see many others. And here is another study for 3 million patients and 231,000 of all fractures, and you see striking, like within 2 years, we have fracture even base of the skull, 3.3. So I stratified with the highest increase is base of skull calcaneus, vertebral-thoracic fracture, almost very others, upper ulna, ribs, first metacarpal, and 1 to 7 for even toe. So here's the discussion. What is the osteoporotic fracture? I mean, the low energy fracture has to be extended to any other low energy fracture, not only to major osteoporotic fracture. That means also even the toes. No, I think that we have to reconsider the definition of the osteoporotic fracture. That means low energy fracture. This is definitely not only hip, humerus, radius, and spine, but many others. Patella, pelvis, malleolus, and others. So this is something what you have to think about in the future. It seems very difficult, this calculation and estimation. I think that AI will help us as it does now, but we know that there are also side effects. So I said this information which you have to collect can be done by the AI that does automatically with the patient. Then I can watch the patient and assess grade, sitting in the chair, facial impression, ocular impression, and a fall risk. And may propose, the doctor may calculate, of course, the imminent fracture risk in percentage, and will suggest decision to the doctor, but we know that the decision is only doctor does the decision and take responsibility for that decision. In this way, I came to the end, and the summing up. The imminent fracture risk make a high probability of fracture within 1 to 2 years. 1 year will be half of them, and in 2 years will be 53%. It is the same as the imminent fracture risk, as high fracture risk. In decision making, in the same. In some understanding, there are some differences, but we can forget it. IOF, based on FRAX calculation, its definition is that the very high or imminent fracture risk is in patient in whom FRAX is above the upper threshold. It may be found that even a lady have no osteoporosis according to WHO, I mean more than minus 2.5, say minus 2. But if we enter to a Nux fracture, another fracture risk, so like recency of fracture, type of fracture, falls, and many others, so she may land in the very high risk. American Association of Clinical Endocrinology guidelines are based on opinion readers and are categorical. That's if you have one category, meaning recent fracture, of multiple fracture, or fracture on treatment, it is very high risk, but also includes over the very high level of FRAX for MOF. And what is general agreement that patient very high risk of fracture should be treated with bone-forming drugs, and this is the whole story. If a price will be similar of those drugs as antidisruptive, definitely will treat every patient with osteoporosis, say 1 or 2 years, with bone-forming agents, and then follow with also cheap antidisruptive. That will be all for today, and thank you very much for your attention. I appreciate any comment or question. I will try to respond on that. And this is the strict lecture. I invite you to watch all of them, and I hope you like it. Thank you very much again for attention. Thank you very much.